Hey guys, so in this video we're going to be talking about sepsis, all the classifications, but first I would like to talk about what type of shock sepsis falls under. So it falls under distributive shock, and that's important because I think it's really important that you understand what's going on in a patient's body, and that can always help you to find the right answer. So distributive shock is one in which your patient has systemic vasodilation. So this vasodilation means that your vein goes from being, let's say, this big to this big, and your blood volume doesn't change, it remains the same, and so now it has so much more space, and that's what creates your hypotension and your tachycardia, because your body is fighting so hard to get the blood around in all of this increased space. So this creates a hypovolemia. You didn't actually lose any fluid at this point. Your blood vessels just went from this big to this big. And so you need more volume to fill the same blood vessels. So after that occurs, then there is an increase in capillary permeability. So then you do start losing intravascular volume into the third space. Then because you're losing volume and you've lost pressure, now you are starting into hypoperfusion of tissues, organ systems, cell death, and so forth. So in this video, we're going to cover all the classifications of sepsis and the medical management. I'm excited to get started. So the first classification is SIRS. It is Systemic Inflammatory Response Syndrome. This is the beginning. So it has 4 different qualifications and things that you have to meet in order to diagnose SIRS. So the first one is a white blood cell count of less than 4 or greater than 12. The second one is a temperature of 96.8 or greater than 100.4. The third one is heart rate greater than 90 beats a minute. And the last one is a respiratory rate greater than 20 breaths per minute or an arterial partial carbon dioxide less than 32. These criteria are considered overly sensitive. They can indicate sepsis in patients who do not have sepsis. They have other conditions. However, because sepsis is so severe and time is of the essence when we are treating sepsis, we continue to use this pathway to initiate treatment because it saves patients. A fifth thing that some providers will order to kind of help rule out like sepsis versus something else is procalcitonin. If it's elevated, it's a really good indicator that your patient is septic. So sepsis in and of itself is a life-threatening complication of infection. It occurs when our body's natural immune response that happens when we are fighting infection causes our body to fight itself. To diagnose it, you take the SIRS and then you have a confirmed infection source. I would like to note here that you only have to have 2 of the SIRS criteria met to initiate the sepsis pathway. So the next classification is severe sepsis. This is characterized by organ dysfunction, and that's indicated by an elevated lactic acid, hypotension, kidney dysfunction, which is indicated by elevated creatinine or urine output less than 0.5 ml per kilogram per hour for more than 2 hours, liver dysfunction, which is indicated by a bilirubin greater than 2, coagulation dysfunction, indicated by elevation of platelets, PTT, and INR. Hypoperfusion begins and is indicated by lactic acidosis, which means you have a decreased pH. Abnormal mental status, looking at lethargy, confusion, agitation, and decreased capillary refill. Severe sepsis is usually accompanied by multi-organ dysfunction syndrome. So this means you have dysfunction in more than one organ system. So if your patient was admitted with respiratory failure, now they're also having kidney dysfunction or heart dysfunction, and that's severe sepsis. So septic shock is our last classification of sepsis. This is classified by the presence of persistent hypotension even after appropriate fluid resuscitation. And this means they're going to require vasopressor therapy to correct the hypotension. Severe sepsis is usually not severe. Septic shock is usually accompanied by multi-system organ failure. So if they came in with respiratory failure and now have kidney dysfunction, it's progressed to kidney failure or heart failure, which means that the organ system in question is now not functioning at all. Okay, so now we're going to talk about medical management of sepsis and septic shock. So your first intervention is to get your antibiotics on board. The goal is to get your antibiotics on board within the first hour of finding SIRS criteria and diagnosing them with sepsis. So this is usually a broad spectrum such as Rocephin or azithromycin, followed by vancomycin. Sometimes they do a different antibiotic for the second antibiotic, but those are the most common. Side points to make here: you are always going to draw your blood cultures before you administer antibiotics. You do need an order for this from the physician. However, at most facilities, your sepsis protocols are nurse-driven, meaning that you can place the order for blood cultures and be policy supported in doing so. Another side note about blood cultures. Blood cultures have frequent contamination rates and short draws. This leads to improper treatment, which can keep your patient in the hospital longer, have an increased mortality rate, and an increased patient cost. So it is really very important that you follow every step that you are taught in doing your blood cultures. It's also very important that if you contaminate the site after you have cleaned it appropriately, that you start again. It's what's best for your patient. Ultimately, it means that they get to go home sooner and they get better treatment. The next step is fluid resuscitation. We resuscitate patients at 30 mils per kilogram. That's how we dose it. And you want to get that in within the first 3 hours. If your patient has a history of heart failure, do monitor them closely for signs of volume overload. This looks like new edema in their lower extremities, crackles in their lung fields, alteration in oxygenation. So if they were statting like 98, 96, and now they're statting 92, 90, then you're probably encroaching on fluid volume overload. Ultimately, they do need the fluid, but we do not want to overload their heart, so we can slow the rate down and assist them with vasopressors until we get them fully fluid resuscitated. The next step is an antipyretic if your patient is febrile, aka Tylenol. So if they're awake and can swallow a pill, then go for it. They can have it orally. If not, Offermev is the IV version of Tylenol. Most of the metro hospitals have this. I don't know that most of the rural hospitals carry it. And then after your fluid bolus is complete, if your patient is still persistently hypotensive, we're going to start pressors at this point.